Good morning. We are here as an expert panel from Aster Medcity to discuss hypertension. And why are we discussing hypertension today? May 17th is the World Hypertension Day. And why did we choose this subject? First, I will introduce all of you and then we will introduce the subject. So we have Dr. Anil, who is a lead consultant in cardiology. We have Dr. Unni, who is a lead in nephrology. We have Dr. Bobby Workey, who is the lead in interventional neurology. Now, why are we discussing hypertension? Hypertension is a very common lifestyle disease. It is a non-communicable disease. It targets the brain, it targets the eyes, it targets the heart and the kidneys. Now, if you ask me the prevalence, it's very difficult to say because it varies from place to place, country to country. It depends on the age of the individual and it depends also on the sex. All these things come into play. Now, Dr. Unni will tell us the causes of hypertension, but before that I would like to say a few words more. And that is one, hypertension, the most common one is essential hypertension or primary hypertension. And 70% of the people with essential hypertension, it is hereditary. We have environmental factors like the age, the sex, obesity, diabetes, dyslipidemia, smoking, alcohol, increased salt intake, decrease in potassium, all these can be reasons. So, do you not think that I should introduce or tell our audience what hypertension is first? So hypertension, before we go into hypertension, I would like to say that the blood pressure in an individual is divided into a systolic BP and a diastolic BP. And the normal systolic BP is 120 millimeters per mercury and the normal diastolic is 80 millimeters per mercury. So when do we say a person has an elevated hypertension? I hope you are agreeing with me on this. We say the BP is elevated when the systolic is more than 120 but less than 129 and the diastolic still remains 80 millimeters. Then hypertension, we have three grades or three stages, stage 1, stage 2 and stage 3. In stage 1, the systolic BP is somewhere between 129 and 139 and the diastolic is between 80 and 89. That is stage 1. In stage 2, we have the systolic which is more than 140 and the diastolic more than 90 millimeters. And in stage 3, the systolic is more than 180 and the diastolic is more than 110. So these are the various stages of hypertension. Now we will go to our expert panel and tell you what are the causes of hypertension. So Dr. Unni, I think you as the lead in nephrology should tell us the causes of hypertension.
Broadly, hypertension can be divided into two. One, what we call as essential or primary, where we mean that there is no obvious cause which could be determined for the cause as cause of hypertension. And the second group is secondary hypertension, wherein we are able to identify a direct cause which is responsible for the rise in blood pressure. Under the secondary causes, we have various organ system diseases which are affecting, starting with kidney. Both acute as well as chronic kidney diseases cause hypertension, majority of patients. Then we have various diseases of the endocrine system, diseases of the adrenal, thyroid gland, pituitary gland and so on, wherein again the patient presents with hypertension. The third category of causes would be diseases which affect the blood vessels, those which affect the main blood vessel in the body called as the aorta, or its branch to the kidney called the renal artery. So if there is a narrowing in the renal artery, again the patient presents with hypertension. These are the three broad causes of hypertension.
So does this mean that in the majority of cases with hypertension there is no cause?
Yes, the majority.
That is the essential hypertension or the primary hypertension?
That's true.
Which we are seeing more commonly.
Right.
Does the secondary hypertension have any importance?
Yes, it is important because if you are able to identify a cause and if you can treat it, the hypertension can be cured.
So it is important for us to find out whether there is a cause.
Oh.
And what is the role of the kidney in hypertension?
Kidney diseases cause hypertension. both suddenly occurring kidney disease like acute kidney diseases as well as kidney disease which happen over a period of time, chronic kidney disease. Both of these patients do have hypertension because kidney is important for excretion of salt and water from the body. So when you have a kidney disease, there is retention of salt and water in the body, and that is the most important cause of hypertension.
So a primary kidney disease can cause hypertension.
Yes, that is true.
And hypertension can cause kidney disease.
Yes, hypertension in the long run can cause a kidney damage as well.
Okay. Dr. Anil, we have a lot of cardiovascular diseases, coronary artery diseases and other cardiac diseases. Does hypertension play a role in this?
In fact, hypertension is one of the major risk factors. Hypertension is directly responsible for coronary artery disease by increasing the stress on the heart, promoting atherosclerosis in blood vessels, and even contributing to narrowing of arteries. So, hypertension alone has an important role, but when it comes along with diabetes and along with elevated cholesterol, even normal levels of cholesterol can cause blocks in patients with hypertension and diabetes. So, that is something important we have to understand. And hypertension, as Dr. Uni was pointing out, has many reasons. But I would say hypertension is more of a condition which causes diseases rather than hypertension being a disease. You don't have to say, I am a patient of hypertension. Maybe if you control your hypertension, you can prevent blocks in your heart. As Dr. Bobby pointed out, you can reduce strokes. All these can be. So I would say it's more of a disease maker rather than a disease by itself.
So in short, we would call it a risk factor?
A risk factor for diseases. So being a hypertensive doesn't make you a patient who is bedbound or anything, but if it affects these target organs like the kidney, the brain or the heart, so that's what we have to emphasize. Everyone should try to control hypertension and prevent heart disease, prevent strokes, prevent kidney disease.
So a patient with hypertension could be asymptomatic.
Most of them are asymptomatic.
Should be important for him to treat it to prevent organ damage.
In fact, the theme for this World Hypertension Day is know your numbers. So you might be moving around with 140, 100, 150, 110 and not knowing it. By the time you develop a headache with hypertension, it might be quite late in the time and might be a precedent for a stroke or something.
Other than coronary artery disease, that's blocks in the heart, can it cause any other?
Actually, it can, with the shear and stress on the blood vessels, it can cause aneurysms. Some of the patients can have narrowings in other than blood vessels to the kidney, as Dr. Uni was pointing out, and you can have narrowing to the blood vessels of the leg, peripheral artery disease. All this is much more common in hypertensive, all the more when it's associated with diabetes.
Can it push them into heart failure?
Heart failure, the commonest cause of heart failure is hypertension. If you continue into 80s and 90s, the hypertensives are the ones which go into heart failure also.
So it is very important for them from the cardiac point of view.
Very important.
Dr. Bobby, Dr. Anil has spoken about the cardiovascular diseases. What about the cerebrovascular diseases? Does hypertension have a role in it?
Yes, ma'am. First of all, the brain is one of the most metabolically active organs in the body. So it requires about 55 ml per gram of tissue per minute to be able to nourish itself by supply of oxygen and nutrients. Now, this whole blood supply of the brain is very tightly regulated to a network of very fine vessels. There are basically 4 vessels which go up from the aorta, go and branch into different parts of the brain and supply it with the required nutrients or the required rate of flow. Now, when there is hypertension, like Sir was saying, this BP is maintained within a very narrow range. When there is hypertension, what happens is that the arteries try to respond to it in abnormal ways so as to regulate the flow of blood and keep it constant. But unfortunately, when hypertension becomes chronic, what happens is that the blood vessel changes itself and because of factors like smoking and cholesterol, the blood vessels become thicker, they become narrower, they become more tortuous. All of these lead to various effects on the cerebral vasculature. For example, hypertension is one of the most common risk factors for what we call ischemic stroke, where some of the blood vessels get blocked due to cholesterol deposits or due to tears in the blood vessels. And also in cases of intracerebral bleeding, when you talk about hemorrhagic strokes, this population of patients, what happens is that because of chronic hypertension and elevated BP, the small arteries of the brain form small blebs called microaneurysms, which can actually rupture and then produce bleeding into the brain. So in that respect, when you look at it, hypertension is one of the major risk factors for all sorts of cerebrovascular diseases.
So cerebrovascular disease as such is a very debilitating disease.
Yes.
So you would not want hypertension to cause that, so you should have to control it.
Yes.
Now, ischemic strokes, are they similar to the coronary artery disease?
They are, in most cases, they are due to some sort of atherothrombosis, but then unlike coronary artery disease, with the primary feature is some sort of cholesterol plaque which ruptures and causes occlusion. Hypertension can also cause strokes through other mechanisms, like for example through tears in blood vessels and dissection, by making the heart enlarged and going to atrial fibrillation, which is an irregular rhythm of the heart, and thereby causing the heart to throw clots into the cerebral circulation, or by shutting down small vessels, which we call lacunar stroke, or by all sorts of vasculopathies, by generally increasing the tortuosity of vessels. So hypertension can cause ischemic stroke through a variety of mechanisms.
Okay, if somebody comes with an ischemic stroke, would you follow the same mechanism like doing an angiogram and things like that?
Of course, ma'am. So right now the whole concept of, we were actually, stroke neurology was actually years behind or decades behind the cardiological interventions. But now we have realized that it is just like in cardiology. If you have a heart attack, we do not just take an ECG and treat the patient. You have to have an idea of what is going on in the cerebral vessels or cerebral vasculature. So now the current standard of care is to do a CT scan or an MRI, and along with them get a cerebral angiogram, which tells you what kind of artery is blocked, whether it's a large vessel, whether it's a small vessel, and based on that information, we decide what sort of therapy the patient has to receive.
And in addition to that, you will target the hypertension, dyslipidemia if he has a dyslipidemia, and that. So the management roughly is the same.
Roughly, but the only thing is, during, unlike MI, where you might tend to bring down the BP so as to reduce the load on the heart, in a stroke, hypertension is somewhat of a compensative mechanism. So the brain is somehow trying to preserve perfusion to those areas which are ischemic. So we do not want to lower it too drastically or too dramatically. So we give them some sort of what we call permissive hypertension. That is, we allow the BP to drift or float towards about 180, 100. And then once the acute period is over and we are sure that everything is stable, that is when we try to bring antihypertensives and then try to reduce the blood pressure.
So if I will say, so during the acute phase, you don't want it to be low.
Yes.
But to prevent a cerebrovascular accident, you want it to be on the lower side.
Yes,
Is that right?
that's right.
Dr. Muni, suppose a patient comes to you with hypertension, what are the investigations you order?
The primary aim would be to see whether there is a cause for the hypertension which is identifiable. So as we discussed, we need to do the test for finding out whether he has a kidney disease, whether he has any disease of the endocrine system, whether any of his blood vessels are diseased. So those will be the investigations. The second aim would be to see whether there is any damage of the target organs, which will include the eye, that is retina, heart, kidney and the brain. So whether any of these target organs are diseased has also to be investigated. So these are the primary investigations.
So we've discussed partly the effects on the target organs, and Dr. Anjan, I want to know, how will we measure the blood pressure? What is the apparatus? How will we measure it? Where will we measure it?
Normally, all of us know, we all started using mercury manometers, and that was the standard for measuring blood pressure. But then now, mercury has become environmentally unfriendly, the toxicity of mercury and the problems of disposing mercury. Now, the international standards have gone away from mercury manometers, they've gone to well-calibrated digital measurements. So, we have to make sure that the patient is comfortably seated and at least 5 minutes of rest, and then only make a measurement. Anybody knows that if you are excited, if you are stressed, the blood pressure goes up. So try to get into a baseline state and take the blood pressure on the hand in the sitting state. And first time when you are checking the blood pressure, it's almost always better to sitting and standing blood pressure. And do not diagnose high BP with just one reading. You might need a number of readings before you decide that this person is a hypertensive. And now, if some of the guidelines have even dictated that 24-hour BP monitoring, not in the hospital setting, that is what we call ambulatory BP, is also required for measuring, for assessing whether one patient needs to have a treatment or not. Most importantly, other than the single reading, like Dr. Uni was pointing out, if there is a target organ damage, we know a single high reading also merits starting a treatment. So measurements are important. Make sure the patient is comfortable, and if on the first time you should take measurement in both the upper limbs both the upper limbs and even if possible upper and the lower limb blood pressure as part of the evaluation of high blood pressure.
Okay. Bobby, does it make any sense? There are so many antihypertensive drugs. When the patient comes to you with a cerebrovascular accident, do you have any particular choice on the drug?
In the initial stage, like I said, ma'am, what we do is we tend to use IV antihypertensives. There are a whole lot of medications. One of the medications that we commonly use is called IV labetalol. So we use those kind of medications to bring down the BP slowly. But after the acute phase, then among the antihypertensives, I don't think there's really much of a, I mean, you can possibly choose depending upon various factors, other factors, you can choose the best or optimum drug for the patient. But I don't have a particular medication choice as a drug of choice for stroke.
Dr. Anil, will you have a particular choice for any antihypertensive?
We all know that we all used to use beta blockers as the first one. Beta blocker is actually acting on the sympathetic nervous system. But a lot of studies have shown that this beta blocker is not good in the long term and it has side effects also. So as a primary choice, now we would consider using an AC inhibitor or a calcium channel blocker to start the treatment with. And then add on if you want a diuretic. Diuretic means something which removes the salt content from the body. So preferably to start with an angiotensin converting enzyme inhibitor or an ARB, a blocker of the, again it's acting on the sympathetic system, and add on a calcium channel blocker. If this doesn't work, then we add on a diuretic. And only after using all these three medicines we should say that BP is not controllable and look for other causes.
Do you have any reservation on the diuretic?
Diuretic, especially in the elderly, I would be worried that they go down on the sodium in the long term and they'll come drowsy, confused and all. And they are not metabolically very friendly, so again they can increase the sugars and all. So use diuretic if required at the lowest dose. That is my suggestion.
Okay. Suppose your patient has coronary artery disease. Is the choice of antihypertensive different?
Definitely the AC inhibitor and the ARB, they are good for preventing left ventricular hypertrophy, relaxing the heart, especially if there is any LV dysfunction. But if there is angina, chest pain, or if there is a narrowing of the arteries which cannot be cleared by other means, then a beta blocker which lowers the heart rate and the blood pressure would be better.
So would it be correct to say that the choice will depend on the target organ involved?
Depending. If there is no target organ involved also, a younger patient we may not put on a beta blocker. You have to individualize. That's, I think, more than evidence-based medicine, now we should be talking about personalized medicine. Each patient, we should find out what suits him better. And most people are worried about the side effects. In fact, the more literate you are, the less compliant you are likely to be because of the worry about the side effects. So each patient we can find out which group suits him best, what achieves control, and then go ahead with the treatment.
Dr. Only, what is your choice on antihypertensive? Do you have a particular choice?
Yes, I mean, all of us know that there are several groups of antihypertensives available, several classes or several chemical structures of antihypertensives. But to me, I would entirely agree with Dr. Anil. A best antihypertensive for a particular patient is what suits him best. The primary aim is obviously to control the blood pressure. If you choose any drug and if it's not able to control the blood pressure, then there's no purpose though. The primary aim is to control the blood pressure. After achieving that, maybe there are certain specific indications for certain drugs. For example, if somebody has heart disease, you will choose one drug over another drug. Third point to be considered is if you have any contraindication for a particular group of drugs, obviously you can't use it. Fourth would be that it should be a drug which is affordable, for which the patient is affordable. So that cost is again a factor for patients. Ultimately, if somebody can tolerate a drug and blood pressure is controlled and he doesn't have any side effects, that's probably the best drug for him.
Okay. Is there any contraindication in your field for any of the drugs, the ACs and the ARBs?
Yeah, the group of drugs called AC inhibitors and ARB, angiotensin receptor blockers, do retain potassium. So patients with advanced kidney disease or kidney failure may not very often tolerate these drugs because they develop a high level of serum potassium. So if at all we have to use this, we just have to monitor serum potassium. And if he doesn't tolerate, we may have to withdraw it.
Okay, they're not contraindicated.
They're not really contraindicated.
They can be used, but with caution.
But with caution.
And the patient can benefit from it.
Yes.
Okay. Dr. Bobby, are there any special situations in your field where hypertension is seen? Any special conditions?
Other than stroke in special conditions, sometimes we do find patients who have autonomic dysfunction, for example, patients who have complicated forms of Parkinsonism. We find patients who have what is called supine hypertension. That is, when they stand up, the BP goes down, but when they lie down, the BP is very high, and they have a lot of autonomic dysfunction. The autonomic or the automatic centers of the brain are going to some sort of disarray. So those patients, it becomes a problem because it's very difficult to treat them, because the moment you lower their resting or supine BP, when they stand up, they go into what we call orthostatic hypertension. Other than that, there are no other than cerebrovascular disease. Generally, by and large, there are no other diseases that are associated with hypertension.
Okay. So you agree on the medication part with
Yes.
your colleagues. Now we have diabetes is very common, and almost every patient with diabetes has hypertension. So they have to be targeted. The diabetes has to be targeted, and the hypertension, which is very important. Patient with diabetes and hypertension have a very high risk of target organ involvement. But I find that most of our patients are frightened. They are frightened. They think that the drugs have side effects, so they are frightened to use it. But I would like to tell them that the diseases, diabetes and hypertension, they have side effects. They affect the brain, the eye, the heart, and the kidneys. So that is what they have to target. Would you agree with that?
Very true. It is the target BP. If you don't achieve, these organs are damaged by the hypertension, not by the drugs. That is something we have to convey even to some of the other physicians in other specialities.
Yes.
That BP medication does not spoil the kidney. BP medication will not cause weakness, tiredness. I think all this was because of the initial beta blocker overusage. So now modern medicines, you can have a normal quality of life, and you can ensure that you can have a long life by making sure your BP is controlled.
So Dr. Muni, adherence to medication would be very important.
Absolutely important. The people who have hypertension have to understand that they need to take the medicines regularly, on time.
Yeah.
Keeping time is
Very
extremely important. And in addition to medicine, their lifestyle practices have to be proper. Eat less of salt. Salt reduction itself is going to bring down the blood pressure. Avoid smoking. Regular exercise. Avoid putting on weight. All these are probably important in addition to taking medicines.
Yeah, one thing we discussed was the diuretics, and then we said they are good. But at the same time, we are saying reduce salt. So many of our patients understand that it's completely going off the salt. I think additional salt, is that a better word, or you want them to be restricted on this?
Yeah, it's definitely not a good idea to go totally salt free. So the advice is probably you take half of normal salt.
Yeah, but they should use it in their food.
They should use half.
Shouldn't go completely off.
They should.
I think that's a very important message because and we have special situations like pregnancy, the elderly. In pregnancy, what is the difference between essential hypertension and in pregnancy?
Pregnancy-induced hypertension is there, and hypertension can coexist with pregnancy. In fact, pregnancy-induced hypertension is more, earlier we used to call toxemia of pregnancy. There were some special toxins which are implicated. But the important thing to remember is we have even lower standards for BP in pregnancy, and we cannot use all these agents that we so easily use in other conditions because they may affect the unborn child. So you may have to be using specific medicines, like I think the obstetricians favor the calcium channel blockers, beta blockers to a certain extent only because they can cause intrauterine growth retardation. And the older drugs, the alpha-methyl-dopamidol, are safer in pregnancy. Never to use the more commonly used AC inhibitors or ARBs. Even if a young hypertensive is on these medications, the moment the pregnancy is detected, we should get them off these medications. So medication management is very important for hypertension in pregnancy.
And would they also differ in the sense that once the pregnancy is over, their hypertension gets cured?
Most of them, the BP settles down in 6 weeks. Most
so
of them.
They can go off the medicine.
They will go off the medicine. 90%, 95% come off the medications. Very few of them stay hypertensive, and when you inquire about them, they would have had a family history of hypertension. So it could be a young onset hypertension precipitated in pregnancy.
Dr. Bobby, do you feel that many of your patients who come in with a hypertensive crisis knew they were hypertensive but didn't take the medicines because they got frightened?
Significant majority do that. In fact, we find that, like we were discussing before, that they are more scared of the side effects of the medications And for years, actually, many of our young stroke patients have been diagnosed with hypertension and have not taken medication. So that is indeed a significant.
There is a fear that once they start an antihypertensive, it is lifelong. So it is lifelong not because they started the treatment, but because the disease is lifelong.
Yes.
So we wouldn't use the term cure for hypertension, but we would use the term control.
Yes.
So our message would essentially be that they have to take treatment. And many of them are frightened. Would you agree to that?
Of course.
So they should seek medical help as soon as possible, and there's no harm in taking the
There
medication.
is no harm, there is only benefit that you can achieve from taking medications, and you should be on regular follow-up with a.
They could have avoided a stroke, a
Yes.
disability,
Yes.
they could have saved their life. So the adherence and timely intervention is very important. Dr. Uni, do you agree to that?
Yes, absolutely, absolutely.
They could have avoided a kidney disease.
Correct. As Dr. Anil mentioned earlier, people should understand that hypertension is not a disease per se. It's a state of his blood pressure being higher than normal. So for that the treatment has to continue. Otherwise, the price to be paid will be loss of an important organ.
So many of the mistake when we say that it is lifelong is just keep eating the same medicine. Should they not come to their doctor for follow-up?
Yes, and absolutely essential because the blood pressure keeps varying. The dosage of the medications would have to be altered. Sometimes the medication has to be changed from one group to another group based on the patient's
Can they do it on their own, or they have to
The
apply
patient has to come to a physician to do this.
for proper BP checking and evaluation of the drug and the
Absolutely.
status at least every 3 months? Would you
Yes.
recommend?
3 months at least. And in addition, they need to check whether the hypertension is causing any end-organ damage. For those, again, they need to come to the doctor.
Dr. Anil, do you
Yeah,
have to?
in fact, most patients will ask, what do I benefit from lowering my blood pressure? Now, there is data to show that if you keep your blood pressure under control, if all hypertension in the world is treated, all are treated, then you can prevent more than 50% of the strokes, more than 50% of kidney disease, and I'm sure 50% of heart disease. And if the diabetes is controlled, blood pressure is controlled, and you keep your LDL cholesterol below 70, there's a chance that we cardiologists can go off work much earlier. The number of heart attacks, strokes, kidney disease will come down to a great extent.
So any patient who is diabetic, hypertensive with dyslipidemia, their chances of leading a normal life are much more if they are on proper medication.
Exactly.
And if they are under proper guidance, not treat themselves. That also would be important.
And another question they ask is, do I need to take lifelong medicine?
Yes.
Now, a simple thing I tell them is, if you want your life to be long, take
Yeah.
lifelong medicine. And you can have a normal life with medications. That's what something they don't understand. With medicine, they feel they'll be tired, they won't be able to do normal activities. We have so many examples of patients doing everything normal, staying hypertensive for 20, 30 years without any problems on good medications.
One of the biggest problems we have is patients go for alternative medicines. But what I would tell them is, we have no idea about alternative medicines. We only know about what we have studied. And we know that these drugs control hypertension,
Yes.
that they are safe, and when to adjust them. Would you agree with that?
Yes. Of course, there is very published data on most of our drugs, which, when the easy part is that you know, if you just type in something, you know what the side effects are, what the interactions are, how you need to adjust the medications. But if you go and take medications which have not been thoroughly researched, which then you end up in danger of hurting your organs more.
So we will not be the best persons to tell them, but we will tell them about our medications, that they are safe, they should be used. Do you want to sum up this? I hope it has been quite useful for our audience. Would you like to sum up this?
I would sum up by telling that each adult in modern day should know what are their numbers. Know your numbers. That's the theme for this World Hypertension Day. What are the numbers we're talking about? We're talking about blood pressure, we know about the cholesterol and the sugar. And maybe your body weight, is it ideal for your height and age? So if you know your numbers, you know are you at a risk of anything. And once you know if your blood pressure is high, you should treat it. If your sugar is high, you should treat it. If your cholesterol is high, you should treat it. Now treatment need not be medications. Like Dr. Umni was pointing out, lifestyle. These are all lifestyle conditions or lifestyle disorders. So if we can control all these things by lifestyle, a good diet, a healthy way of exercising, keeping your weight down, you can prevent the onset of all these things. You might be talking about primordial prevention, even preventing all these disorders from happening. And once you have this, if the lifestyle does not control it, you should take medications to control them. Medications are not harmful. You can take them and lead a normal life and prevent kidney disease, prevent heart disease and strokes. I'm sure if this is followed, we'll have a much more healthy society.
Many people have a wrong impression that it is enough only to have a lifestyle modification. But I think we mentioned that there is a genetic and hereditary.
Very true.
So if you have a hypertension of 180 by 120, a lifestyle modification alone may not be sufficient. So I think that also is very important for patients to understand. And another very important thing is I have many patients who said, doctor, my BP was all right on your medication. It was 120/80 for 3/4 reading, so I have stopped it. Is that correct?
Yes. It's absolutely wrong to stop a medicine because the blood pressure is normal. The very purpose of giving a medicine is to make it normal. So if you stop the medicine, obviously it's going to go up. So the patient should never stop the medication without consulting the doctor.
In fact, most of these medicines act for 24, maximum 30 hours. So you stop it, your body is going to push the BP up again. It is a system within you which is abnormal. The fact that the people believe, oh, I start a medicine, I become dependent on it, so I will not start. Let me try it. It's not a question of that. You are only correcting that for 24 hours. We still maybe have in the future, we may have a single injection which may control BP for a year, but that's still far away. We still need to take tablets daily to control blood pressure.
Dr. Bobby, Dr. Uni, Dr. Anil, I think we are enjoying ourselves. So if we go on and on, we are going to discuss it. So we have to stop this and start it, and some other day we have to do a more detailed. We agree with that? So we have to wish everybody a very happy, how do you say, hypertensive day? Would you say that?
Yeah. Maybe it's a time for all of us to recollect what is to be done for hypertension on World Hypertension Day, and make sure we stay happy for years ahead with controlling BP.
We want our patients to be healthy, wealthy and wise.
Wise.
So thank you very much.